It's one of the most frequent cause for repeat surgery is incomplete surgery. Unrecognized or recognized but not treated due to the surgeon limitation, and left and never mentioned aspect of the surgery. This could be peritoneal disease, this could be ovarian surgery, this could be deep endometriosis surgery, this could be hysterectomy, this could be chest surgery. So if you leave tissue behind, the patient will come back.
Endometriosis impacts at least 1 in 10 women, and many go undiagnosed or misdiagnosed for many, many years. So in today's episode, I'm bringing to you an abbreviated version of my top 5 all-time downloaded episode with Dr. Tamer Seckin, a world-renowned surgeon for endometriosis. And this is clearly a popular topic on the podcast, so feel free to go to the webpage and type in endometriosis to learn more about other episodes with experts and patients alike. So now let's listen to Dr. Tamer Seckin as he gets real about endometriosis.
Even in medical school, I was in OBGYN ward since the third year or second year of my medical school. More than 25 years right now, I'm exclusively focused on this area. It has been a passion, obsession, addiction to this disease due to its challenge and its being so complex. It was something like calling and inviting me to battle this along with the patient, gradually increasing your ability to win more battles with the patient's help. You kind of feel like you can serve these waters. It's very exciting field to be in, actually. There's no cookbook recipe for an outcome of a good dish here. Every endometriosis is different. Every patient is different. Patient is different. Their disease is separately different. So there's a difference between the two concepts. And you're a surgeon and you do the best you can.
And I must disclose to the audience why I wanted to interview you. So I came to you after a 3-year journey of being told I had unexplained infertility. And the late Dr. Braverman did tests on me. And he said, I think you have silent endometriosis, because I had no symptoms. But I think also why I wanted to talk to you is not just because thank you for giving me my child, but with Dr. Braverman, of course. But also I went to the Endometriosis Foundation of America conference, the 10-year anniversary in 2019. And the doctors that you brought together at that conference, it was just absolutely amazing to both have a day where the doctors all got to talk and then the patients got to hear the specialists as well. And it became clear there that there's only a handful of experts in the world who know endometriosis. And because of the training in medical school, a lot of the experts are self-taught. And since this is such a complex disease, I thought, why not have someone who clearly understands this, already works with the experts around the world, and really help women understand more about the disease so that they know what to do. So thank you for making time with the over-Zooming during COVID and your busy surgery schedule to be here and help educate the women. But just for those who are still getting to know endometriosis, maybe you could just briefly describe the disease and the complexity behind it.
Endometriosis itself is an inflammation that is driven by estrogen sensitivity of the cells. And if these cells happen to be the cells of the endometrium that causes monthly periods, and it's located outside the uterus, guess what? It is monthly. There's a stimulation of these cells outside the uterus, and that monthly stimulation causes micro periods, so-called, within the body that does not escape. That micro periods, small periods, mini periods that doesn't escape eventually causes inflammation, because body wants to kick them out or eat them up and cannot have enough power to eat them up, but starts shooting them with inflammatory chemicals and bullets, let's say, and then leaves the residue, war zone, which is called inflammatory war zone, with collagen and fibrosis and more development of these tissues obviously progress. And these fibroses eventually, every time there's fibrosis, there's nerve tissue around, new blood vessel formation, the inflammation. So these nerves get trapped within the inflammation, and even a little lesion becomes a big source of pain. So bottom line is we brought this concept of inflammation, and years later, people start talking about endometriosis inflammation. Everybody defined endometriosis. As you can tell, the definition of endometriosis is simple: presence of endometrial glands and stroma, endometrial cells outside the uterine cavity. That is not enough. Presence of them with inflammation is what really causes the symptoms. So without inflammation, defining endometriosis just cells out of the uterus is not adequate definition. It is the inflammation that is taken care of or excised along with the glands that you see that creates the better treatment and ultimate treatment, actually, that leads to tissue diagnosis and everything else we may talk later. But it is the inflammation. So inflammation and getting rid of inflammation, understanding inflammation is important, because if you do not understand the disease, you cannot treat it. Even though we don't know how the disease formats, how does it start, but overall recognizing the tissue with problem and getting rid of it is the key. And inflammation is formats in different way. There's visual recognition is different. It's not really pigmented black lesions or cherry colored lesion or of red colors that you see. Many of the endo lesions are not that color. They are white. They are under bright light. They are not easily detectable many times. That's why many times endometriosis patients do not get treated adequately. In my practice later, I found out these women who had pain, as we discovered laparoscopy, trying to look inside. I mean, I always believed in what the patient said. I was really influenced or affected with how smart woman was with bringing their issues and very open about their issues. And once we look, and it's hard not to believe them when they say they are pain, and you give certain medicine and you look inside later and you see endo, then you realize what you were taught was not true. And that was really the calling, and you just attracted them. As you treat them, as they feel better, that you push forward and you do more and more and more. And suddenly I found myself in this land of very complicated cases. And with my background of very heavy surgical background with vascular surgery, breast surgery, that, I was a surgically oriented guy. I mean, I basically went in and I took care of things. Then if you really follow, microsurgery is the ultimate surgical precision techniques. You can get the best result. Today, the ophthalmologic surgeon, eye surgeons, and brain surgeon, and ultraplastic surgery techniques are all based on microsurgical principles. In gynecology also, at that time, the most important aspect of fertility was treated by tubal surgery. So tubal surgery was done under microscope, and we would go for every little capillary. All these things together really put me here today talking to you.
Does everyone need laparoscopic surgery?
First of all, the symptoms of endometriosis is also one of the symptoms is no symptom.
Which was me.
Okay? But the only symptom becomes fertility issues.
Right.
The prevalence of these patients, we do not know, but I think it is vast, incredibly large. And that's why we really do not know exact prevalence of endometriosis. We may know the incidence, which is during when you attempt to do things to go inside for any surgical procedure, you see endometriosis, or when people have symptoms, you go in, you see this much of endometriosis. So that incidence is around 6 to 12% maybe. There's also some group patients who get pregnant, or some infertile patients never get doctor's attention. So there's that group over there in the corner. We have no idea who they are.
One of the things that a lot of the reproductive endocrinologists have talked about is they don't really, evidence shows that endometriosis doesn't necessarily impact fertility. And as a result, they tend to not necessarily feel the need to recommend laparoscopic surgery in most cases. I do think in the American Society for Reproductive Medicine findings, they do say if you have late stage that you should get the laparoscopic surgery, but a lot of the REI say, well, the data showed early on that it's not necessary. So it's really interesting to see all these professionals disagreeing, which is why I wanted to bring you on, because I think women need to understand there is major disagreement. The way doctors are trained, it's not enough, and we really have to fight. So I think just helping women understand all these things from your expertise is so important today.
Let me just clarify something. Who needs surgery? First of all, it's important to underline the fact that I never tell anyone they need surgery. I want patients to tell me they want surgery. They are the one who lives with pain. They are the one who I am with them for 15 to 1 hour consult twice or 3 times prior they decide to go forward. But it is the life that they live within with their loved one, within that family they're from. If it's impacting on their daily functions, impacting to their happiness, impacting to their productivity from school or to job, well, obviously something needs to be done. It's important that how their symptoms are so pronounced in some patients and they're made to believe it's normal is mind-blowing. And it comes with sometimes certain cultures imposes that. Those mother-daughter relationships are so crucial. And sometimes the type of ambitious personality of some women, really, they have a way of blocking their symptoms while their disease are really so extensive that they have nowhere, they're pinned against the wall. And then they say, let me have surgery. But I think that's why awareness is important. If women recognizes certain symptoms of endometriosis, what we know as IBS, let me just clarify. When it comes to endometriosis, IBS is BS, is the biggest BS. Many women sucked into that concept of IBS, not realizing or not being recognized that their symptoms flaring up with periods never brought to attention of anyone. So any symptom of IBS, I call this ergus, okay, endometriosis-related bowel symptoms, all right? Which are they? Constipation, diarrhea, cramp, bloating, gas, you name it. Those group of symptoms, if they are flaring up with period and they're progressively getting worse, it's almost diagnostic clinically, presumptive diagnostic signs from the symptoms that you can say that this is mostly endometriosis, because awareness of symptoms, we're talking, awareness of some painful periods that are gradually getting worse and not responding to non-steroidal pain medication. Let's not get to narcotics, non-steroidal pain medication. Pain during deep intimacy with deep penetration, deep contact, progressively or later showing up in symptom chronology. And this bowel symptoms popping out or from the get-go is 3 cardinal elements of endometriosis symptoms that we need to make public and doctors aware. And these are not easy subject, confidential, pain, shame-producing issues that people don't want to bring up. So even doctors are preconditions for that. They don't really ask the question.
Let's help the women figure out what they can do. And I think,
So awareness, I think we were at awareness. Yep. Awareness is the key. Early diagnosis and awareness. That's why in a meeting in Croatia in 1993, I was with Lona Hamelshoy, the president of endometriosis organization, right? How early diagnosis is the best prevention and detection is the only way to halt the disease and to move forward. I think, and only with awareness you can bring that early diagnosis and prevention issue.
Right.
And endometriosis is really, really a disease you can diagnose early, and you can prevent the disease jump from one stage to another. And you really can prevent a lot of every bad things that happens to endometriosis patients, whether they lead infertility or hysterectomy or losing an organ or bowel obstruction. Many of these things could possibly very well prevented, knowing from my example of my patient population.
Is prevention always getting surgery? Like, for example, you take someone like me who was asymptomatic, endometriosis was never brought up. I'm well educated. I've been in the biopharmaceutical industry. I am a chemistry major. I didn't really know anything about endometriosis until much, much later, and even my fertility journey, which was in my mid to late 30s. And now, obviously, with social media, there's a lot more awareness. But again, if you don't know to go on social media about endo, you may not find it. So how does someone know, get diagnosed? Because right now, again, the diagnosis is the laparoscopic surgery. And if someone is in their early stages, then it's harder to find out through an in-office exam, which even in those cases, endometriosis is missed. So how can someone get diagnosed early? Are these the patients who have that severe pain at a young age, and they should have the right to fight for the right treatment?
Well, first of all, probably right now speaking, time is changing. So
that's true.
Many girls know their mother's history. First of all, if there is in the family history of his mother has endometriosis, or aunt or sister or someone, so there's a very high chance that you may be in that pool. So that's one part. Even though there's no symptoms, one has to bear in mind they need to, that part of awareness, number one. And symptoms, many times we teach women that certain symptoms of even painful period, with a little bit of everything that I mentioned before, it doesn't have to be very severe, but if they're dancing together, they're all three of them are around, but if they're not sexually active, significant bowel symptoms with painful period and laterality, one side, even though they are normalized, so-called normalcy is being pushed by doctor or their even mother, or no, don't worry, I have it too, don't worry, it's going to be, but self-awareness is a key. They don't have to be very severe. So we could really recognize certain things without panicking. That one, we're talking about the symptomatic group right now. And how can a woman know? Awareness is becoming another, serious part of education. So that's why in foundation, we started this high school education to young girls and boys too, because a man can recognize things in a relationship that women may not even want to bring. In doctor's perspective, if you don't need a laparoscopy to call somebody with very high certainty they have endometriosis. In my population, out of 100 cases I don't have more than 3 patients a year. That's 1 out of 100 in my population, that I go in and don't see any single endometriosis. Okay.
Wow.
Completely. However, there are type of endometriosis that in some women it is massive. In some women it's 1 or 2 lesions. So let's roll the tape back. It's easy to diagnose endometriosis by when they have image findings, like on sonogram you see the cyst, or MRI you see bowel nodule, or da-da-da. That's why they say, the fertility doctors, when they say 50% endometriosis, they're talking about endometrioma when there is cyst, all right? Endometrioma is an end stage of endometriosis. When the ovary gets a cyst, chocolate cyst, it's already, the thing has been cooking there for years. Peritoneal endometriosis, how it starts. And for that, there's no biomarker. For that, there's no image studies. When you look at everything normal. So you're complaining about pain, lady, but everything is negative. Sorry, there's nothing I can do for you. However, if you really ask the right questions to that lady about their period synchronology, or their period and their symptomatology that comes along with the period, if you ask the right question, the answers will start popping out. And most of the time, they have been imposed as normal things for that woman. They assume it's normal. It's normal to have pain with periods. It's not normal to have pain with periods. I mean, anything more than 1 day and doesn't respond, second day pain, third day pain is not normal. Pain should subside after the flow starts. When the flow starts, the pain should also go down. And if the pain is continuing after the flow and staying and lateralizing, right side, left side, that means something. You got to ask the question in a very fragmented microscopic format. The pain, all right? After the period's over, is the pain still there, all right? How is the bleeding? How bad is the bleeding? Tampon plus tampon are very minimal. Tampon plus tampon means a lot, and those women have significant pain. So where is the pain? So is it uterine pain or out of uterus pain? Uterine pain is crampy, midline. Women know what central pain is. They know it's there in general. I mean, but right. When the pain is on the side, that means this is the same pain. After the period starts, pain still continues. Also, we have pain with ovulation. Why? Because if there's endo around, ovulation is very painful. And it's lateral, it's one side consistently. That shows that there's something there. And also the presence of GI symptoms like nauseousness, like general bloat, like endobelly they describe, right? The patients say endobelly, I feel bloated, I feel terrible, all those things with GI. GI is a terrible feeling with GI symptoms. So that is all endo-related symptomatology. So a doctor, if they're aware, I'm talking through you to all these GI doctors particularly because they really get these patients and they are the least informed people on endometriosis. And you know what? When GYN doctor doesn't know or doesn't have the courage to push forward to a diagnosis and they start sending the patient on the wrong path, it's like you're directing a train instead of going to Washington. Suddenly you change switch the shelter, the patient ends up in Nevada, in Las Vegas. That's kind of thing, and never comes back. Anyway, so awareness from the doctor's angle, these things, you don't need a invasive laparoscopic surgery to have an idea, strong suspicion, strong presumptive diagnosis of endometriosis. The real scientific diagnosis and the real, in other words, evidence of the crime or the pathology is when you see it under microscope, not even laparoscopy. The real evidence is under microscope.
And just to add to what you're saying, for those who may not fully understand, so endometriosis can grow in a lot of parts of the body, and just going to, and correct me in how I'm saying this, but because it could go in the bowel, et cetera, like OBGYNs aren't necessarily trained in all of these different parts of the body to do the surgery. And you want to make sure the patient is safe. So once they do the laparoscopy, because you may not always know where the endometriosis is growing until you're in, it's important to have available these other surgeons just in case they're needed, which I know is tough to say for someone who doesn't live in a city like New York where that's easy to get. But the reality is it's important. And I hope that people who are listening to Dr. Seckin can see like how hard and complicated this disease is. And it's worth doing the surgery right, should the surgery be needed. I've read so much about all these things you can do with your diet, and, removing toxins from your daily life are really, really helpful with managing the inflammation. At what point does surgery play more of an important role? Like, is it as simple as if someone is in earlier stages and not as much pain and they start managing it through diet and other things and their symptoms subside, that's enough? Is it always that surgery is needed? And then if the surgery is there and if it's the right surgeon, can endo come back?
With the right education and by this support system that pushes for all non-surgical management techniques from diet, exercise, and understanding inflammation and and the toxin. And inflammation and toxins are similar concepts actually.
Right.
Inflammation is internal toxins, right? Inflammatory molecules are toxins, not friendly material. that comes out and that systemic effect of endometriosis, that's fatigue, that is not feeling right, that's headache, that's you name it, that's that inflammation, the effect of inflammation. So toxins are something that you ingest from outside and makes you feel lousy and da-da-da. So overall, before surgery, if that balanced issue with diet, exercise, and other support measures are formatted, I like to underline the value of exercise, because estrogens, there's catechol estrogens. Estrogen and adrenaline are related in a way that exercise, you can really eliminate excess estrogen. In other words, the endometriosis is estrogen sensitive tissue. Okay, so exercise itself is such a regulatory effect on the overall estrogen is metabolized and organ effect, whether it's the way you feel, the way your uterus responds. So those elements are part of the success of surgery when the surgery is decided. Nothing will get rid of that endo away, even though you may take Lupron, the most powerful menopause drug, or Oralisa birth. They may subside the symptoms, but it may not. So people can live with those symptoms with like birth control pills. Excellent for a while. I mean, if they can manage the symptoms with it, even though it doesn't get rid of endometriosis, I mean, people will live a normal life and it can change. So you may not need surgery. But when the decision comes, the pain medication and birth control pill don't help and symptoms are still pronounced. When the surgery is necessary, or in case of infertility, then, like you were saying, the right surgery, what is the right surgery, who does the right surgery, what needs to be done right is a different thing.
First, how does a woman know who the right surgeon is, given there's no database? And by the way, there are databases, but I would say that those databases aren't enough, just given what I know about endo and women's health. So how does a woman know who to go to?
First of all, let me clarify. OBGYNs are not trained as true pelvic surgeons, even though they are the most proximal doctors to do pelvic surgery. But in their 4 years of training, they are with all these focus on medical, legal exposure in hospital systems and emphasis on obstetrics. Half of the time, more than half of the 3/4 of their time, even I would say even more, is focused on obstetrical aspect of OBGYN. Patients should understand these. So if a doctor is really doing obstetrics in their practice and they're doing your endometriosis surgery, that's the biggest red flag.
Okay.
Don't do it. Okay. That's not the right person to do it. You can't. And on top of it, one really has to be honest about, and the patient should ask the right question. Hey, how many have you done last month? There are people who really do this quite frequently. There are people who don't do it frequently. And it's not easy to find these. But if you really want to find the right person, this is the second question. How many have you done last month, last year? And how many years have you been doing? The third thing is there a dedicated team with you? And who's your other surgeon team? Who's the leader of that? And I think the next question is transparency. Would you take pictures or would you record my surgery? That's very important. If the surgeon does not hesitate to do that, that's 2 thumbs up. I record all my cases. Not that because I know I'm not perfect. So if patient comes with 2 years later with pain, my record, even my own record that I dictated, does not tell me everything in my professional experience. I go back to the tape. I think patients should have second opinion, and we need to get organized also to give them more empowerment to express themselves and educate them. These principle of clarity or transparency and truthfulness to the patient is important, but the patient has to dig that too. The patient has to ask that. If you don't ask the right question, you're not going to get the right answer. And you will know the opportunity whether someone is answering you truthfully or not.
Tell us more about getting the repeat surgery.
So there are 3 factors for repeat surgery.
Okay.
One is the patient, one is the doctor, one is the disease. These are 3 factors, but one is the most important factor is not the patient, One of the most important factor, it's the doctor. It's one of the most frequent cause for repeat surgery is incomplete surgery. Unrecognized or recognized but not treated due to the surgeon limitation, and left and never mentioned aspect of the surgery. This could be peritoneal disease, this could be ovarian surgery, this could be deep endometriosis surgery, this could be hysterectomy, this could be chest surgery. So if you leave tissue behind, the patient will come back. You leave it behind on big chunk, the patient will come immediately. But then recurrence of pain does not mean endo is back either.
Let me play devil's advocate. So since we don't know why endometriosis begins, how do we know that if you do the surgery and take all of it out, it still can't come back anyways?
I can tell you, I know this much. Endometriosis never comes back in the area it is removed. I am talking from my own very self-critical personality and for my own observation. I have gone to many times. I mean, maybe I operated between 1 and 12, 1 and 10, 1 and 15. That ranges from year to year. But out of those patients, I go back and look.
Okay.
They come to me and I go back. Wherever I remove the endo, most of the time, I never see as much endo as I saw. If I get even 20 suspected areas, or very few of them are positive. But what is prominent in those patients? There's fibrosis, there's scar tissue formation. And overall, that perception of scar tissue causing pain may evoke the same circuits of pain. I call that sometimes phantom endo. Okay. In the absence of finding so much endo in someone, that the same person going in and finding no endo could be also characterized as phantom endo or central pain, which has a lot of other components to it.
You mentioned before about asking doctors how many surgeries they've done. A good endometriosis surgeon or one of the experts, how many would they do in a given day or year?
My answer is you put it together the way it's supposed to put together. Who does this? This endosurgeon should do it. If you're calling someone else to do it, that person has nothing to do with it. That's where the trouble starts.
Okay.
Because many times you don't have a team, the doctor who comes in to fix things that for a deep endo doesn't know how to do things right, and the complication starts from. That's why endosurgery gets a lot of bad rep, and the doctors are afraid to do it. You gotta fix your holes. And endo has no mercy to any organ. It will go through it. You got to fix bladder. And you know what? The patient has to know about it, but truthfully, recovery is fantastic. I mean, there's no issue on that. So it's the same thing as C-section repair. It's the same, anything that you wound, you close, it's the same thing.
When does a woman need a hysterectomy? Are there cases where they get them and they shouldn't have had them? I mean, this just breaks my heart, and I really want women to know before they make such a hard decision.
I think this is the heart of the ethics of endometriosis practice, where doctors feel that they can do anything which they believe or whatever writes in the text, and they could justify, move ahead and do it. And I am collecting these cases, hysterectomy on young women that comes to me. Unfortunately, these doctors are in some big Facebook groups. They are one of the prominent doctors in those groups. And it's hard to say. We can't really, ethically though, it is very concerning. And having a one woman, 20 surgeries until the age of 20, and the 20 surgery, last 10 is done robotically by the same surgeon. And then having hysterectomies done or ovaries being removed in the end, or one woman, because of the recommendation of one group taken from, let's say, from Boston or New York to someone else and getting hysterectomy done at the age of 19 is synonymous to any crime you can imagine. I don't want to name it. Standards have to be defined, and I think patients who practice removal of organs and too many repetitive surgeries, we have to agree among us what the standards are.
When is a hysterectomy, from a medical perspective, the right choice?
First, yeah, besides women's choice of requesting, patients may request.
That is true. Some do, yes.
Some requests, okay? Out of sexual preference, out of personal feeling about their periods, even for birth control, with risk involved and with the right person, that's a different thing. But medically, in endometriosis, hysterectomy is indicated when there is, first of all, massive adhesions around the uterus. So in other words, every time uterus contracts, theoretically, it pulls on every other organ. And no matter what you do, as long as the uterus is there, that is going to happen. So that's one. Massive, extensive adhesions, scar tissue. The second is adenomyosis, when endometrial tissue invades into the uterine muscle diffusely. When there is compounding pathology, what are they? Let's say fibroid uterus, multiple fibroids, 20, 30 with endometriosis. That's something. You can't really save that uterus effectively. When there's other issues with the endometrial, like hyperplasia, that, obviously there's other indications of compounding. But the trick is, hysterectomy is not necessarily removing the ovaries. Hysterectomy itself also not adequate. Only itself alone, naked, is an incomplete procedure for endometriosis, because endometriosis disease is outside the uterus. So you got to go outside the uterus and clean the mess and the mud out there to call it endometriosis related hysterectomy. Anything short of cleaning the endo around is not the right treatment. So I want to just add that too. Medical indications are mostly it is adenomyosis and fibroids. Besides that, obviously there could be multiple polyp, familial other diseases that can compound the indication. But there has to be visible problem.
There's a test out there. It's Receptiva DX, and they basically take a sample of your uterine lining, and they test for the BCL6. And the way they describe it is, if it's positive, it's basically testing for inflammation, and it's more for women who are struggling with fertility and miscarriages. And if you test positive, then it's not saying you have endo, but it says you likely do. Whereas if you test negative, you don't have to be concerned. But it's much more around miscarriages and fertility. And just given, you work so much with women, and obviously you're an endo expert, I just wanted to get your take, just so women have an idea from different, experts on what to think about when it comes to something like this. Because I think it's so valuable to finally have a diagnostic tool to provide information that doesn't necessarily require multi-$1,000 surgeries, which I'm not minimizing, by the way. I'm just saying, it's good to have options.
I think the BCL6 coming to as a diagnostic tool or guiding tool. I mean, of course, we know what BCL6, it's a oncogene protein, basically it's a B lymphocyte-based antigen, which is defines the progesterone resistance. And many of these patients who have miscarriage, they have endometrial bed is not soft enough. They don't receive and host the coming embryo conception enough solid bed to implant. So what happens is the same tissue, because endometriosis is originally endometrial related same tissue. We have an article coming on that. It's the same, really, clonally. It's the endometriosis and endometrium clonally similar tissues. So these tissues are also BCL6 presence also is a semi-diagnostic for endometriosis. In the case of particularly the group of silent endometriosis, it is not a big deal for people who have symptoms.
Right.
But for people who miscarry, their symptoms are so minimal or normalized, they don't see as a symptom, but repetitive miscarriages, these women, and in my practice, I've been seeing them vastly lately. We're getting a lot of referrals with high BCL6 or over 1.5, 1.7, coming in with one or two miscarriages, or even without miscarriage history, but some sign of endo, they may elect to go for diagnosis and elimination of the inflammation, because what that could mean many, many failed IVFs in my opinion, it's an opening a door for so many women.
So last question for you. What is your greatest hope when it comes to endometriosis?
Wow, this is a big one. Well, I think realistically, getting some sort of standardized approach to the best treatment techniques in a methodical way that applies to women, and with early diagnosis before the disease jump from in a peritoneal phase into a organ attacking phase. You cannot eliminate estrogen. Estrogen is part of life. This disease will be part of us, part of the modern woman's life. If we can find way of early diagnosis and having tests that like BCL6, BRCL6, in similar way with early awakening and the public awareness, if we can manage this disease without surgery, finding that particular molecule that will not cut the effect of the estrogen will still be around, but only affect the endometrium, but not promote the endometriosis of inside, it will be a true bliss. And I think people are working on this though.
Yes.
People are working on it and we know who they are. But overall, at this stage, if people have unsuccessful surgeries, if their pain level are persisting after procedures, this and that, I don't think they should lose hope that disease is not curable and things like that. With good endometriosis is highly treatable disease with the right approach. And many of these women do get pregnant, have a normal life, and even pain-free and pain-tolerable life is ahead of them, enough to forget about endometriosis and not even talk about it afterwards.